Really great job. Thank you so much.
You're welcome.
Hang around because we're gonna have some questions. Okay. Okay, for our last talk. I had to survive without my phone for the entire talk because it was up here with you. I almost died. Okay. Thank you so much, Sam. All right, for our last talk, we're gonna head it in a related direction, but a different topic. Dr. Sarah Tempin's coming back up to talk about women, power, and gynecologic cancer care.
Thank you. And I hope I can keep, oh, sorry.
No, I'm gonna go this
Okay, whatever works. I'm going to keep talking a little bit about how gender stereotypes are bad, and maybe from a slightly different perspective, but I hope we keep that conversation going. So one of the things that I think I started talking about a little bit in my last talk, and when I talk about the timeline of inclusion of women into clinical research, is this idea that that really women have and women have only been included in clinical research since 1993. This doesn't only go back to 1993, right? This goes back all the way to Aristotle, Hippocrates, and the birth of medicine, as we think about it in Western medicine, where a male body was considered as the default human, and the male animal was considered as the default animal model. And so fundamental biology was assumed to be shared and extrapolated into women's health. So we have worked very hard recently in my office to try to expand our definitions of sex and gender and the ways that they influence health. And part of that is moving away from an idea of sex and gender both being binary constructs, and rather instead thinking about them as being multidimensional variables that have various components that all combine into one human being. And one person may not have all of the same sex-related variables that align with one sex or another. And we know that all of these things influence the fact that women and men have different diseases, disease burdens. It's not only gynecologic cancers and other female-specific conditions that are different, but it's also things like autoimmune disease, which 80% of those patients are women, and cardiovascular disease, which presents and progresses very differently in women. And so I just show this graph to demonstrate, and these are global burdens of disease. Women and men women do live longer than men, but women and men have very different patterns of disease conditions that they experience, with women having actually much higher burdens of disease across every age group, and predominantly and specifically between what we call the reproductive age groups, or I've been scolded about this too, so I'm looking for new terms, maybe premenopausal. But it is a marked difference for women between the ages of 20 and 49. When we think about this as it relates to cancer care, we know that that first part of what we consider sex is anatomy, and anatomy really drives our organs at risk and is really one of the most fundamental categories of how we use to define cancer. Sex-specific cancers are very common. Breast cancer is the most is not sex-specific, but it predominantly affects women, and is the most common cancer that women experience. Cancers of the uterine corpus and other gynecologic cancers are extremely common as well. But even in cancers that are not related to a sex-specific organ, the experience of cancer is different in the female population than the male. Cancers of the thyroid and the biliary tract are the only two cancers that are more common amongst women than men. All other disease sites are more common in men. There are also fundamental differences in physiology between between people of different sexes. Male cells, cancer cells, favor a carbohydrate metabolism, whereas female cells favor a fatty acid metabolism. There are differences in genetics between the male and female cancer patient. We have talked a lot about the immune system. X chromosome inactivation occurs in the female chromosomal complement, but not in the male, which creates a mosaic of the X chromosome. And most of our genes that code for immune proteins actually are found on the X chromosome. And our hormonal environment, estrogen, testosterone, progesterone, all really influence disease risk, influence how we experience disease, and are therapeutically manipulated for many different types of cancer. We also know that sex influences the way that we respond to treatments. There are sex differences in all phases of drug distribution, including absorption, metabolism, and excretion, due to differences in body mass index, body composition, cardiac output, the immune system that we just talked about. And historically, when we determine doses of drugs, these are determined in very small phase 1 trials where we have groups of 3 patients, each getting a dose of drug, looking for a maximally tolerated dose of drug, in which we don't really account for sex differences in the way that drugs are metabolized. And this is potentially one reason that we see that female participants in clinical trials and across cancer therapeutics have a much higher rate of experiencing adverse events to chemotherapy, immunotherapy, targeted therapy than male patients. And so because my office is the Office of Research on Women's Health, you know, while we've defined sex as a multivariable component, multivariable factor that influences health, we've also been doing a lot of work to think about how gender influences health and how gender is a social and structural determinant of health. And we have actually recently been using definitions from a recent National Academies report that looked at gender identity and sexual orientation and how to measure that. And so we've been defining gender not only as gender identity or one's sense of self and one's self of being a man or a woman, but also in terms of social factors such as gender roles and norms, gender relations, and power, or who controls resources within our society. We do know that gender influences all of those things that we think of as social determinants of health. This is a 5-component wheel that's become very familiar to a lot of people, that of some of the influences of health that are social and structural, that affect the way that we access and receive healthcare. And so when you think about gender in this wheel, you know, to me, I think about the neighborhood and built environment, and how is that really different for women? Well, women actually are more likely than men to use public transportation, for example. Men are more likely to have a car, so that influences how you get back and forth to doctor's appointments. We also know that even though men and women are equally likely to receive education in this country, the educations that they do receive are decidedly different. And when you look at this, and this last little box on the end of the chart is a United Nations report that looked at levels of gender inequality within a society or a country. And you can see that gender inequality, as societies become more unequal, it's actually bad for women, but it's bad for men also. It's bad for the entire population. And this particular graph looks at life expectancy. So when we have sexism within our society, it actually means that we all live less long. When we think about gender influencing the cancer continuum, we know that there are multiple different factors, from individual level, patient level factors, provider and patient interactions, organizational structures that include the availability of care and quality of care, as well as policy considerations that include reimbursement for care and national cancer priorities. Gender identity really does influence who provides what kind of care. We have known since 1972, when the quotas on women in attendance in medical school were lifted, that women tended to do specialties or get training in fields that were considered women's work, things that had to do with the care of women, the care of children, that were more communal, whereas men tended to do more procedural specialties and specialties that included things like cardiology, orthopedic surgery, neurosurgery. And so we see that reflected in our workforce today, where women are most likely to be overrepresented in pediatrics and obstetrics and gynecology, and are most underrepresented in fields like urology or orthopedic surgery. Gender identity also influences cancer risk. We know that 40% of cancer cases diagnosed in the United States are associated with potentially modifiable risk factors, things like alcohol or drug use, tanning behaviors, outdoor activity, lack of physical activity or exercise, and norms of masculinity and femininity influence these behaviors. We also know that gender norms, or the expectations of other around our assigned gender or our gender identity, influence the amount of social support that we have. And social support is vital after a diagnosis of cancer and influences the ultimate outcomes experienced by patients. Women are more likely than men to have a caregiver, but that caregiver tends to be of higher quality for male patients, who are more likely to have a spouse taking care of them, while women are more likely to have a child as a caregiver. Gender also influences our perception of the health of women. And this is, I'm going to just return for one moment to Aristotle and Hippocrates, who described the term hysteria as concordant with the word for uterus, or hysterica, that in ancient Greece, the uterus was actually the cause of all problems in all women, from everything from anxiety to insomnia, depression, really basically everything. And it's only been, it only took 2,000 years to get that removed from our criteria that we use to define illness. But we do still use the word hysteria when we talk about the surgical removal of the uterus, and dismissal of women's symptoms remains really disturbingly common within the medical community. Gender relations, or the way that we interpersonally interact based upon the gender that is perceived, also influences the way that women receive care. There is just innumerable lay press articles talking about women going to the doctor, having their pain dismissed, not being listened to, and how women are perceived when they do go to the doctor's office. And what I'm showing on the left-hand side here is an analysis by Naomi El-Haddad, who looked at thousands of different ICD-9 codes and diagnostic codes, and whether a diagnosis came first for men or women on average. And for nearly every single one of those codes, women experienced a delay in diagnosis. When we look at this for cancer care, even for cancers that are not sex specific, over half of those disease sites, women have a significant delay to diagnosis when it's compared to men. And so when all of these things accumulate, we do see real differences on the population level for women's health compared to the health of men. And sexism is really associated with worse healthcare outcomes. So Trish Homan, who is a sociologist at the University of Florida, created a metric to measure state-level sexism based upon various policies, representation in government, things like this. And what she found was that actually, if you live in a state where sexism is more pronounced, you are more like, both men and women are more likely to have chronic disease, have poorer self-rated health, and have poorer physical functioning. And so one of the things that I'm really proud of from the National Institutes of Health from this fall was a Lancet Commission report, and the National Cancer Institute created a global health report on the state of women, power, and cancer. And they put together this, really, I think, nice figure where they talk about the multi-level institutional and individual levels where sexism combines with other social factors to influence patients all along the cancer continuum. But what I really wanted to talk about today is how gender then can influence the way that we think about sex. And I used this Emily Martin children's book that she created in 1991, which she labeled The Egg and the Sperm. And this is a fairy tale that talks about reproductive health, really. But the words that we use to describe the female reproductive tract are words are failure, wasting, or expelling of debris. The egg is described as behaving femininely or passively transported or swept along a fallopian tube. The sperm, on the other hand, are streamlined, active, competitive, with strong and efficiently powered tails. And this colors the way that we think about conditions that are female-specific. Female-specific cancers and cancer in general can overlap. Cancer stigma in general can overlap. And I think that we do see this when we think about gynecologic cancers. The female reproductive tract is often pathologized and stigmatized, and this stigma can be internal, interpersonal, and or institutional. We see this in a lack of cancer screening or lower rates of cancer screening in sexual gender minority populations. That is not good for human health. We also know that lots of people think that cervical cancer, for example, is directly caused by promiscuity. And so all of these things have led me to think very deeply about whether we're actually listening to women. And ovarian cancer, that case of ovarian cancer has really weighed on me for most of my career, because I was taught that this is a silent killer, that, one day a woman wakes up and she has ascites and she has, she needs a huge surgery and massive amounts of chemotherapy, and she's going to die from disease. But it's not actually the way that this happens. And I think I practiced as a gynecologic oncologist for many years. I saw women go from doctor to doctor to doctor, complaining of indigestion, getting a colonoscopy, seeing a urologist, going to another doctor, getting a CAT scan, finally getting another intervention, and taking quite a bit of time to get to a gynecologic oncologist. And when you look at billing records, actually, 3/4 of patients with ovarian cancer have had their symptoms for some time before their diagnosis. Most commonly, it's abdominal or pelvic pain. Sometimes it's bloating. It may be difficulty eating or urinary symptoms. And gender intersects with other social factors to influence health. This concept of intersectionality is not new. It was coined by Kimberly Crenshaw in 1989, who's a lawyer. And it's a theoretical framework for understanding how multiple social identities, including race, gender, sexual orientation, socioeconomic status, ability status, all intersect at the micro and macro level to reflect interlocking systems of privilege and oppression. And it's not an additive thing. It's not like you have this one thing here that's related to your race and something else that's related to your place of origin, and that's why you have whatever health condition you have. These things are fluid and very, very individual. But where I think this is important related to gynecologic care is where we see gender and race intersect. We know that endometrial cancer is the only disease site that has been increasing in incidence over the last 30 years. it has been dramatically increasing in incidence and mortality. And when you look at the numbers and you look at the disease sites with the highest racial disparities, they're listed here. They're myeloma, stomach, uterine corpus, uterine cervix, and breast. 3 out of the 5 of these cancers are female specific or substantially more common amongst women. And one of the potential reasons for this is what we've been talking about. We know even for women who experience postmenopausal bleeding, only 1 out of 5 of them doesn't get a biopsy. 1 out of 3 of them who are Black doesn't get a biopsy upon reporting their symptoms. The influence of gender also extends to how we value research. Molly Carnes has been really an incredible voice in thinking about equity for women's health across her career. And she published this study during the pandemic that looked at abstracts and manuscripts based upon the gender of the participants in research. And so what she found, I think, is shocking, but not shocking, that research performed on men was twice as likely to be recommended for publication than research that's performed upon women. This was significantly significant, even when the research on women was felt to have a greater contribution to science without a perceived difference in rigor. And when you look at the funding that we as a community, a public resource, the National Institutes of Health, spend on various conditions, there is a marked disparity based upon the gender and sex of the people who get the disease. This graph looks at the disability adjusted life years within the population compared to the amount of money that's spent by the NIH on the condition. And for conditions that predominantly affect males, we spend on average twice as much money as those conditions that twice as much money over what's expected for those conditions that predominantly affect males versus spending less money than what's expected on conditions that predominantly affect females. And we know that both sex and gender influence clinical research, clinical trials eligibility, we talked a little bit about before, but it's based upon a lot of the eligibility criteria is based upon reference lab tests that differ by sex. These 2 charts just show the average hemoglobin and platelet counts for men versus women. Hemoglobin is one of the most common reasons that women are deemed ineligible for clinical trials. We also know that rates and severity of comorbidities differ by sex. The availability of clinical trials differ by geography, by who is your provider, by what your provider's specialty is, with gynecologic oncologists being difficult for many, many women to access. The ability to travel and take time off is different for women who often have childcare responsibilities as well as elder care responsibilities, and adverse event reporting was not made with women's clinical trial subjects in mind. Women also may report their symptoms or be less willing to report their symptoms because they're worried about being judged or dismissed by their doctor or healthcare team. And so I'm going to end with what was the end of the Lancet Commission report, which is a sort of a new way of thinking about how we approach cancer care for women. And I just really, of course, love this, the label of this, that it's an intersectional feminist framework that considers multiple factors, social factors and biologic factors, and centers healthcare needs about the individual at the center. I'm just going to say, if people are interested in this topic or others, our office does have a quarterly newsletter. We also have several training courses, and I didn't put this on there, but our sister, just based upon the last talk, also our sister office in the NIH, the Sex and Gender Research Minority Research Office, has a course on cultural competency related to gender that I think I will probably add to this as a resource. And we have several educational courses on sex and gender and how they influence health as well. So I will close out the day, and I will just repeat that I'm really so pleased to have been invited.